This is the Executive Guide to Aging, an educational series from Executive Home Care of Augusta. Our belief is simple: better information leads to better decisions. Today's topic is one of the most misunderstood and most costly to get wrong: the difference between home care and home health. Most families are thrown into these decisions in the middle of a crisis, with no time to learn the rules before they need them. That's when costly mistakes happen: money spent that didn't need to be spent, care that doesn't match the need, and families left more exhausted than they had to be. In the next few minutes, I'll give you what each one actually is, who pays, how to tell which one a person needs, and what to do when the answer is both. Why does this distinction matter? 3 reasons, and they all cost something. Money. Home care is usually paid out of pocket. Home health, when someone qualifies, is typically covered by Medicare. Families routinely spend thousands privately for care that would have been covered, or wait months on a benefit they were never eligible for. Recovery. If someone needs skilled nursing and gets a companion instead, the wound, the new medication, the blood pressure, nobody clinical is watching those. Readmissions. Care that doesn't match the need is one of the biggest drivers of people landing back in the hospital within 30 days. The fix isn't complicated. Match the service to the need. That starts with knowing what each one actually is. First, let's talk about home care. This is non-medical support, help with the ordinary business of living at home. What it looks like: bathing, dressing, getting safely from bed to chair, meals, light housekeeping, errands, medication reminders, and simple companionship. Who delivers it? Caregivers, home care aides, and certified nursing assistants who are trained and supervised, but they are not doing skilled nursing. How you get it? No doctor's order, no eligibility test. The family decides, and care can usually start within days. How long it lasts? As long as it's needed. A few hours a week or around the clock, for months or years. The short version: home care is about living, not healing. Home health is the other half. This is medical care, delivered at home. What it looks like: skilled nursing visits, wound care, IV therapy, medication management, monitoring vital signs and physical, occupational, or speech therapy. Who delivers it? Registered and licensed practical nurses, therapists, medical social workers, all working under a written plan of care. How you get it? A physician must order it. There must be a face-to-face encounter, and the plan of care gets reviewed every 60 days. How long it lasts? It's an episode, not a lifestyle. A few visits a week for several weeks, and it ends when the clinical goals are met. The short version: home health is about healing, not living. Here's how home care and home health compare: non-medical support versus skilled medical treatment, caregivers versus nurses and therapists, no physician order versus a physician order, long-term care versus short-term care, 2 to 24-hour shifts versus 30 to 60-minute visits, private pay versus Medicare, family-directed care versus clinically directed care. 2 different services, 2 different purposes. Knowing the difference helps families choose the right care at the right time. Home care is typically paid out of pocket, private pay. Long-term care insurance can help cover it. In some states, Medicaid waivers are available, and veterans may qualify for aid and attendance. Traditional Medicare does not cover home care. Home health, when eligibility criteria are met, is typically covered by Medicare at no cost to the patient. Medicaid and commercial insurance plans cover it as well, usually with prior authorization. Coverage ends once the skilled need is resolved. Here is the point families most need to understand: Medicare does not cover ongoing help with bathing, meals, or daily activities at home. This is the most common and most costly misunderstanding families encounter. Coverage rules vary by state and by plan, so we always recommend verifying benefits before making any decisions. People often think they have to pick one or the other. In reality, it rarely is. The most common answer is both, and when they work together, home care and home health each cover exactly what the other cannot. Here's the typical arc after a hospital discharge. Home health starts in week 1, nurse and therapy visits focused on the clinical goal, and wraps up in about 6 weeks once that goal is met. But look at the math. Those visits are maybe 2 hours a week. There are 168 hours in a week. Home health treats the condition. Home care covers the other 166. The meals, the bathing, the safety, the ride to the follow-up appointment. One addresses the medical need. The other sustains daily life around it. That's what makes them complementary rather than competing services. When the clinical episode closes, home care is already in place. No gap, no scramble, no starting over with a new intake. And that matters because the most common driver of readmission isn't a clinical failure during a visit. It's the unsupported hours between them. The exact hours home care is built to fill. Here are 5 of the most common misconceptions families run into. 1. Medicare will pay for someone to help mom at home. Not accurate. Medicare covers skilled home health when the criteria are met. It does not pay for ongoing personal or household help. 2. Homebound means bedbound. It does not. It means leaving home takes considerable, taxing effort. Doctor visits, worship, and occasional outings are all allowed. 3. A home health aide and a caregiver are the same. They are not. An aide works under a clinical plan of care during an episode. A caregiver works for the family on an open-ended basis. 4. We should wait until things get worse. Waiting is what turns a manageable situation into a fall and a hospital stay. Earlier support widens the options available. Waiting narrows them. 5. Accepting help means losing independence. It's the opposite. Support at home is usually what allows someone to stay out of a facility. For families, the starting point is identifying what's actually difficult right now: bathing, meals, nighttime safety, transportation. From there, the ordering physician can confirm whether the situation qualifies for home health. An in-home assessment is typically the clearest way to determine which type of support, or combination of support, fits the situation. For referral partners, the most effective approach is to submit a single referral covering both service lines rather than pre-sorting the case. Including the ordering physician's direct contact, along with any support gaps beyond the clinical need, helps ensure the right services are matched from the start. And if it's still unclear which category applies, that uncertainty is common. The distinction isn't always obvious from the outside. Describing the situation in plain terms is usually enough to determine which service fits, or whether it's genuinely a case for both. Getting this right from the outset tends to prevent the larger costs, financial and otherwise, of a mismatched placement. Thank you for spending this time with us. I hope you learned something today, or at least found some value in the time we spent together. If you take one thing from today, let it be this: you don't have to figure this out alone, and you don't have to wait for a crisis to start asking questions. That's the heart of why we do this, making sure that when the moment comes, you already know what to do. This is just one topic in the Executive Guide to Aging series. I'd encourage you to check out the other videos as well, and if you found this helpful, subscribe to our YouTube channel so you don't miss the next one. If you have questions about this topic or anything else, we're here. Reach out and let's navigate it together.